Hello, everyone, and thank you very much for joining us today. I'm Deborah Garlick from Henpicked Menopause in the Workplace and Menopause Friendly. And today's subject is tackling prolapse and incontinence. Now, I've got to confess, those two words strike fear into my heart, but putting them into the same statement was even more petrifying for me. But I'm delighted to welcome Dr. Surya Gupta-Wright from the fabulous My Menopause Centre. And I'm sure you won't be able to strike the fear completely from my heart, but as always, knowledge is power. So welcome today, and I'm hoping to learn an awful lot about this and share a lot of information with everybody that's joining us today. And prolapse and incontinence then, what are they and why do we need to be aware of them during the menopause transition? So shall we take them one at a time and say, first of all, what is a prolapse?
Hi, Deborah. Thank you so much for asking me to join you today and talk about it. As you say, unfortunately, it is something that a lot of us don't want to talk about or feel embarrassed to talk about. So prolapse is basically to do with the organs in the pelvis. So our bladder, our bowel, and our womb and vagina, and sometimes the supports that hold those up get weakened, and then they can start kind of hanging down. So we have what's called a pelvic floor. I think most of us have heard about pelvic floor exercises, haven't we? And that's the sort of sling of muscles that are at the bottom of our pelvis. They go from the pubic bone at the front to the back to your coccyx and around the sides as well, and they hold everything. There are also some ligaments or some tissues kind of inside the body that hold things up. And sometimes, unfortunately, often pregnancy and childbirth is one of the really big culprits. Can be through things like constipation and straining, people that have a chronic cough or smoking, and unfortunately a bit of extra weight also can contribute to extra pressure on the pelvic organs, and those supports not really holding them up. And then the prolapse is when usually they kind of hang down through the vagina, so there may be kind of bulges in the vaginal wall. They may not be visible from the outside, or sometimes actually if you look, so if you got a mirror and you held that between your legs and you had a look down below, you might actually see something kind of bulging out of the vagina.
Oh, and that's the bit that I find absolutely so scary, that can happen. And I wouldn't know how to diagnose it or how I would know if I was struggling with it. Many of us think of prolapse of being in much older people. But so how would I diagnose it? And is this something I could experience right now?
Oh yes, and a lot younger women get it as well. I mean, generally speaking, if you're in your late 20s, 30s, and you've got some degree of prolapse, it's probably due to childbirth. And I think what women normally describe is they'll describe a dragging sensation, and that's something that's bothering them, and it's a sort of down in the vagina, that sort of area, something coming down, or they'll feel a lump. They'll feel something. They'll come in to me and say, I can feel something coming down. And as I said, you could look and see something, although an awful lot of women may have some degree of prolapse, but actually don't know. In which case, I guess, the question is, does it really matter? But yes, I mean, if you were examined by somebody and they assessed you, if you've had a couple of babies, you may well have some degree of prolapse.
So you could have a degree of prolapse and it actually get worse, and you might not be aware of it at first, and it might not really affect you on a day-to-day basis, but it can actually get worse if you don't treat.
Yeah, it can get worse over time, and I think that's one of the reasons why we talk about pelvic floor exercises, don't we? And that's trying to kind of strengthen that pelvic floor and help to reduce the risk of prolapse. And also, if you're not doing something, then it can get worse over time. So if you do have a prolapse and it's not really bothering you at the moment, there may be simple things that you can do to prevent it getting worse.
Okay, so there's some things that you can do, but if somebody is on this, is listening to this right now and is thinking, yeah, I think I've actually got this, what do they do about it? Because, many of us can put things off, and you can just think it's nothing. when do you go and get diagnosis, or how do you, is this something that you go and talk to your doctor about?
So, I mean, I think it's these days it's really difficult, isn't it? Because I think a lot of people find it very difficult to access their GP, but it would probably be worth going to see your GP in the first instance and asking if it's something you're worried about. It's just better to get someone to have a look. And if it's been there for a while, there's no desperate rush. If you can't get an appointment for a few weeks, go in a few weeks' time. And also probably thinking about your surgery, if there are a number of doctors there in your surgery, is there a doctor there that's got a bit of interest in gynecology, women's health? And that might be somebody that you could go and see. Or the alternative would be is probably at the family planning clinic as well. You might be able to get a bit of help if you really feel you're not winning with your GP.
But don't put it off.
But don't put it off, exactly. Yes. There's no point in having these things worrying in the back of your mind. And I think as women, we often leave things, don't we? And you're busy running around after everyone else and work and juggling everything. But actually, if there's something there, it's much better to go and get someone to have a look at it and see what's happening.
Yeah, well, it's not the sort of thing that gets better on its own, is it?
No, it's not going to get better on its own. No, exactly. And it's better. It's always better to check. And I think particularly if something changes suddenly, then that's really a good time. And I think it's really important then not to put it off and to get someone to have a look.
Yeah, thank you very much. Actually, and now you've said it can happen, or it can start to happen after childbirth. Then when you're starting to come to menopause, are you at more risk post-menopause of a prolapse?
So, what happens at the time of the menopause, I think probably most of our listeners will know, is that your hormone levels start to drop down, and the estrogen, one of our female hormones, is responsible for helping to increase the elasticity of our tissues. And in the pelvis, as those muscles and the tissues lose their elasticity, then they're much more likely to start hanging down. So yes, it can be that around the menopause time, things do start to deteriorate, unfortunately.
And that kind of brings me, because we've done lunch and learns before on incontinence, and great description to say you've got that sling of muscles that is holding everything in place. Is that why there's the link there with prolapse and incontinence?
Yes, exactly. So, I mean, incontinence is where you're leaking. So either you're leaking wee, or it could be feces or poo that's coming out. And yes, and there's definitely a link between the two. So if the pelvic floor isn't working right, and there are other factors as well with incontinence, but the pelvic floor is quite a big factor in managing continence or causing incontinence.
So this could have a significant impact on somebody's day, can't it?
Oh, massively. Yeah, definitely. And so it is a really important thing that, it's very easy. People don't want to talk about, but it's a really important thing to think about and try and get some help if things are not quite right.
Now, and this is where I'm looking to you for hope. That there is something that you can do about this. This doesn't have to affect your daily life forevermore. What sort of things would really help with both prolapse and incontinence? And as you say, maybe it's the more of the holistic, the sling of muscles that go from my pubis to my coccyx.
So I think just sort of thinking quickly about incontinence, the sort of to think about the different types. So you can have incontinence of feces or poo, so incontinence from the back passage. And I think that's the one thing that we really, really, really don't talk about, isn't it? And I think it's really difficult for women to come forward and say, this is what's happening to me. And actually, as doctors, I think, we'll often ask about urinary incontinence, but we don't always ask about fecal incontinence. And I think that, it's a really important thing if it's happening, that you let someone know, particularly if it starts happening suddenly. But if it's something you've suffered with for years, you should get some help. With the urinary incontinence, it can kind of be divided into two things. So you've got the stress incontinence, which is more related to the pelvic floor, the anatomy of the bladder, the way the bladder's supported. And if that's not quite right, then you get that leaking when you cough, sneeze, running, jumping, walking around. Even some women get it a lot. But then there's another type of incontinence, which is called urge incontinence, which maybe we can talk about afterwards, because it's the pelvic floor that supports all of those things. And things like pelvic floor exercises, which we can all do, can actually make a massive difference. And in fact, recently I was listening to a really amazing physiotherapist talking, and she was saying about it, they sort of feel, don't they, pelvic floor exercises, like you're doing it and what are you doing it for? But actually, she said, if you do your pelvic floor exercises properly for about 16 weeks, 80% of women are going to get a significant improvement, which is actually pretty impressive.
Yes, it is actually. I thought you might say you get 10 or 20% increase, but 80%?
Yeah, I mean,
that's long.
Yeah, and it's not that long. I mean, you then need the maintenance and you do need to keep going with it. But I mean, that sort of feels like a manageable goal. And I think, we can talk, using strategies to help you remember and to get into the habit of doing them regularly, and also maybe even getting a bit of help, like for example with if you could see a physiotherapist that specializes in women's health, sometimes just for 2 sessions could get you started so that you know what you're doing, where you're supposed to be squeezing, how you do it. Because it's all very well, isn't it? People say pelvic floor exercises and it's easy to sit and have a squeeze, but actually making sure you're doing it in the right place and what you're doing is effective and doing it regularly is really important.
Yeah, you're right, actually, because you can do it at home, but you might not necessarily have the right technique.
Yeah.
And so technique's important in this, isn't it?
I think really important, actually. And again, I think that was sort of an interesting point of her talk, actually, that, if obviously it's available through the NHS, there's going to be a bit of a wait. But, if you've got the means and you could pay for 1 or 2 sessions with a physio, that might really be worthwhile. And it's not going to be loads, just to get you going and so that you know what you're doing and to really be able to then, do your 16 weeks to really get the maximum benefit you're going to get from them, which would be good.
And it's really worth it, isn't it? Because when you say things like, oh, you get a dragging sensation, and when I never thought of poo incontinence, to be honest. I'm very familiar with urinary incontinence, but it's for the rest of your life, isn't it? I mean, we're all living for longer, we're working for longer, and actually this is something that's fundamental to good health.
It is fundamental to good health, and obviously it's uncomfortable, but there's and it may you may have discomfort with it, but actually the sort of psychological impacts of it as well, in terms of stopping you from going out, stopping you from doing things. It may affect women working. There's so many far-reaching effects, aren't there, that I think it can have a really big impact on our lives. And so actually trying to address it and deal with it and improve it, it seems like a sensible thing.
Absolutely. So in terms of, if you like, the checklist of the things that you can do to improve the experience, or what's going on for you, you mentioned about pelvic floor exercises. You mentioned earlier that if you're overweight, it might put more
reducing your weight.
So
that's going to be helpful. I mean, general exercise specifically is not necessarily going to help, but I think is worth helpful. But that's a kind of positive, isn't it, generally? And I think it is worth doing. And some exercises, things like Pilates, yoga, you may be actually using your pelvic floor as well, and so they may be sort of good things to kind of think about maybe taking on board. And then as you kind of start transitioning into that kind of perimenopausal period, then vaginal estrogens can also be really useful to help with the estrogen. And even for a lot of women, the majority of women who, if they for some reason can't use HRT, most women can use vaginal estrogen because it's such a tiny weeny dose, and that can have quite a big impact on the elasticity of the vaginal tissues and help with the pelvic floor. And I think it's definitely something worth kind of bringing into the mix.
And well, it is bringing it into the mix, because I had a time when I was sort of struggling with urinary incontinence. I thought, well, for goodness sakes, how come? Because I go to Pilates a lot, and they're always saying about zipping up your legs and squeezing and all of this sort of thing. So I was quite surprised. that, you know, I was experiencing that, but that the S string really worked for me, and now I swear by it, you know, and I think my healthcare practitioner said, well, you know, you only need it for a certain amount of time just while you get it under control. But I'm thinking, well, why? Because I plan on living a very, very long time, and if this is keeping everything healthy and supple, then why would you come off it? It's not like systemic HRT or anything else like that. Not that you know, I plan to be on that for the rest of my life too. But that was actually made a remarkable difference in, I felt, quite a short period of time.
Yeah, I think it can do. And I think sort of previously we used to prescribe vaginal estrogen as a kind of 12 weeks and then have a break. And then when the symptoms start coming back, you prescribe again. And we've very much changed our prescribing now. But it may be that, you know, there are still doctors, you know, GPs are general practitioners, they're not experts at everything. And they may still be prescribing in that way. And so actually, you know, saying actually I would like to try using some vaginal estrogen, but I'd like to try using it continuously, and that then will give you that ongoing benefit from it rather than stopping and starting.
Yeah, well, my healthcare practitioner has said, yeah, fine, we'll put it on repeat prescription for you, and I'm like, oh, thank you very much. I mean, not everybody wants to take HRT, but there's a lot that you can do that is the more natural. I mean, I think exercise for me, I actually dialed down on my exercise while that was happening, because you don't want any, you know, it felt a bit uncomfortable, a bit awkward, embarrassing at times. So I'm glad that it's sort of, I'm past that time now. But even if you don't want to take systemic HRT, then you can still use vaginal estrogen.
You can still use the vaginal estrogen, yes, exactly. And I think also the other thing that's worth thinking about is, you know, pads can be difficult, can't they? If you're trying to exercise and, you know, you don't want to wear a pad and people see the pad, but actually, you know, like now a lot of younger girls use the period pants, don't they? You can get incontinence pants as well, which are just, I find astonishing when you look at them. They just look like a pair of knickers, but actually they hold a tremendous volume of urine, and so actually that might give you the flexibility and the you know, confidence to be able to exercise, and then that has that beneficial effect, doesn't it? The exercise is good for you, weight loss, etc. And so it might be that there are other things you can look at using to help you get to that goal.
Yeah, that sounds like a great tip, actually, because do they work in the same sort of way?
Yeah, they do. I mean, I literally, it's amazing. I mean, if you Google, you know, incontinence pants, it really makes a big difference, and it does. They just hold it, and you don't get wet like girls. I mean, for me, I'm a little bit older, and I never use those period pants that the young girls wear now, and I can't believe that they don't leak, but they don't, and they all use them, don't they? So it's the same thing. I mean, they are there, and it might be nicer than using a pad, getting a couple of pairs of those that you could maybe use while you're exercising.
Yeah, fantastic. Thank you. So I'm looking at the questions, Sally, and I'd like to invite my colleague, Sally. I can see there's lots of comments and questions coming in.
Yeah.
Thank you, Dr. Surya. And so, Sally, shall I hand over to you?
Yeah, absolutely. And yeah, just again, thank you for people sharing their tips and their support for each other, because again, this is what we love about this community, which is really, really appreciated. Okay, so one of the questions was around what are some of the other factors that can cause incontinence? Because I know we talked about prolapse, but what other things may lead to someone experiencing incontinence?
So so we were talking about pelvic floor, but yeah, there is another type of urinary incontinence, and that's called urge incontinence, and that's due to sort of irritability of the bladder muscle. So that's the kind of incontinence where you're desperate to go to the loo, you get home, you put the key in the door. As soon as you put the key in the door, you just wet yourself, and it's usually a large volume that suddenly comes out, or you went to the loo and you just wet yourself before you get to the loo, and that has a different cause. So the bladder's like a balloon, and the wall of the bladder has a muscle that's called the detrusor muscle, and what happens is that can become irritable and constantly kind of twitching, and it's that twitching that makes you want to go to the loo all the time, and you just sort of lose control over it, and so it will just squeeze when it wants to. And again, unfortunately, around the time of the menopause, it can get worse. It can be related to estrogen deficiency, and actually alongside something called bladder retraining, which you can do with your healthcare professional, some vaginal estrogens can actually be really useful in helping to make the bladder wall a little bit less irritable.
Yeah, that's brilliant. Thank you. A few people have asked around the risk following hysterectomy around prolapse. So whether they're at high risk around prolapse following hysterectomy. Just any thoughts on that?
It can be. I mean, the anatomy of the pelvis obviously changes somewhat, and depending on how the surgery is done, it can be the top of the vagina can be slightly less well supported. And so, yes, it can contribute. Although for some women, if they've got a really big womb and they're told the hysterectomy would be useful, actually, if the womb's large with something like fibroids, for example, then actually removing that may help to relieve some of the symptoms they're getting of prolapse. So I guess it sort of depends a little bit on the reasons why the hysterectomy is done, and also how it's done.
Yeah. And again, I think this the same with all of these things. It's so individual. It's why it's so important people do talk to their healthcare practitioner to explain their own personal situation.
Yeah, exactly.
Yeah. We've had some great. Someone said the NHS Squeezy app is really helpful for bladder training. And someone said Sweaty Betty now make leggings that incorporate incontinence pants. So definitely, I think there is some really good things to encourage, because you say you don't want to not exercise.
Yes.
Exercise is actually going to help, but equally, if it's
you don't want to be wearing leggings and a big pad, you may feel embarrassed about wearing leggings and a big pad. So yeah, that's brilliant. That's really good. I didn't know that.
Someone's talked around you mentioned around constipation being quite a risk factor around prolapse, and so just anything around is it important to focus on things like gut health and things like that to, if somebody's struggling with constipation, is that again a potential risk factor, and what advice would you give?
I mean, I guess really what we're talking about is chronic constipation. So obviously any change in your bowel habit, you need to let your GP know. So any change that goes on for more than 6 weeks, if it's something new, then please do tell your GP. Don't just attribute it to kind of what we're talking about, menopause, whatever. But it's the kind of long-term constipation really, and managing that. And so stool softeners, and certainly the first thing to do is to look at your diet, isn't it? And actually, if you can make those changes through healthy lifestyle changes, then that's definitely, I think, a really good starting point, rather than having to take laxatives daily. It's a good point to start.
Okay. Someone's asked around whether it's likely that a healthcare professional would spot a prolapse when they're going for a smear test.
They might do, and I think if a lot of surgeries, the nurse will do the smear test. If it's something you're worried about, you could say to the nurse, I'm a bit worried I might have a prolapse, what do you think? So many women do. I guess you don't necessarily, probably in reality, they're not going to say to every woman, you've got a bit of a prolapse, and point it out, because unfortunately what happens is that opens up a conversation, and they've probably got a 10-minute appointment to do your smear, or 15 minutes, and they've got someone else waiting, and so it can sometimes be a little bit difficult on that front. But yes, I mean, by all means, I think if it's something that's on your mind and you're going for a smear, then mention it.
Yeah, excellent. Someone's asked around, again, additional risk around if they had an episiotomy at pregnancy. Again, is that something that gives, again, potential risk?
So episiotomy or tears can be a risk factor, and then particularly for women who unfortunately have third-degree tears, so tears around the bottom. I mean, that is the big predisposing factor for fecal incontinence. And if hopefully that would have been identified at the time of the delivery, but if it's not, it really is worth going and asking your GP about it and getting referred to a clinic, because they can, sometimes there is stuff that can be done surgically, and rather than just live with it, actually see if there's something that can be done.
Yeah, excellent. And someone said, obviously we know the challenges around being referred and the length of time. So someone said they've been referred to the incontinence team if they've been struggling, and they've got with both urinary and bowel incontinence, there's an 18-week wait just to be able to see someone. Is there anything someone can do in the meantime while they're waiting for that referral?
I would get started on my pelvic floor exercises. I mean, they're not going to do any harm. You've mentioned the Squeezy website. The NHS has a good website on pelvic floor exercises. On My Menopause Centre, where I work as well, we've also got information on pelvic floor exercises. There's information out there, and getting started with that. And actually, you mentioned the squeezy app. I was going to say, actually, it's normally about 6 times a day. And the other thing that I think maybe can sometimes be a useful trigger to help you remember is probably most of us pee 6 times a day. And so actually, it's when you go to the loo, when you're washing your hands, that could be a time when you could try and do a few of your squeezes and if you can get that into a habit to trigger, that can be quite a useful way of kind of integrating that into your normal day-to-day routine.
Yeah, absolutely. And some people have shared that they found removing certain foods and drinks have improved because they find it's really triggering. Again, I think it's that us learning about our own bodies and listening to our own bodies.
Yeah, definitely. And certainly caffeinated drinks, if you've got the sort of overactive bladder type incontinence, can be, really problematic in terms of increasing the problems with the irritability of the bladder. So yes, making those changes can be helpful.
Yeah, fantastic. Someone said, do you come across many patients who with medium to severe prolapse who live with it? I was advised surgery could be carried out, but would probably need it to be redone again in a few years. I'm getting more used to it, but worry about it getting more severe with time and should therefore go for surgery. So again, when is surgery the something that people might want to be exploring?
I mean, my understanding of the surgery really is that if you're going to do it, it's probably your best chance of success is first time. So kind of, maximising your health, maximising your weight, getting all of those things right before you go for surgery is probably going to increase the risk of the chance of it being successful. You can get pessaries which can go into the vagina to hold things up, and they can be surprisingly useful. They're a bit like people don't tend to use them so much anymore, but it's diaphragms, but the diaphragm without the middle bit, so like a ring that pops into the vagina and sort of holds everything up, and they can be quite useful. They do need to be fitted by someone who knows how to do it. Your GP might be able to do it, there might be someone in the practice. Unfortunately, it might also be a wait for the bladder and bowel clinic to do that.
Okay. And some people have asked around exercises. We've talked around pelvic floor exercises. Someone's asked, if you do the exercises for 16 weeks or 18 weeks, you start to get that positive response, do you then have to keep going with them? And I think it's that this is a constant, like any other muscle in our body, we've got to keep exercising it to keep it in good shape.
Yeah, yes, I think it is. It's unfortunately, it's not 16 weeks and then you're done. It's 16 weeks and then you've got probably, that may well be your baseline of an improved state, and then yes, carry on. And there are some chairs and stuff out there that will do the pelvic, you can buy, it's quite expensive, I think, but there are things like, there's a chair called Emsella and stuff that you can pay to go and use in some clinics, and that I think does lots of pelvic floor exercises for you, and you may see some improvement, but unless you then continue doing pelvic floor exercises afterwards, whatever improvement you've got will ultimately decline.
Sally, I think we have one on supplements as well. There's a comment about supplements, Jude supplements, or supplements for urinary incontinence.
Yeah, so those Jude supplements are interesting, and if you it looks really, I think they look very interesting. The studies are fairly small, and so maybe not. I don't know for sure, but I guess there are things out there, and I've met the lady from Jude actually, and she's got the brilliant pants actually. But yes, they might be. There are some supplements out there, but I think also just a degree of caution that sometimes supplements aren't always, they're not as tried and tested, and you can spend a lot of money on them.
Yeah. Absolutely. And I think that the comment, Sally, I've just seen in the chat that says, more intense orgasms, keep them coming and keep doing them.
Yes, that's a good idea.
Which is a nice way for us to end it. And I have to say, thank you very much, Sally, as always, and thank you everyone in the community for your ideas, thoughts, views. I think we've all learned something. So thank you very much, Dr. Surya, for sharing that information. Actually, you did take the fear out of the topic for me. And also something I have never done at all in a live lunch and learn. I Googled, and I think I'm just about to put in my basket some really cute knickers from Moon Cup. And they look absolutely lovely. Why wouldn't you wear those every day? You know, they're not that expensive, and you can keep wearing them and, you know, do without the pads. So, so that was an absolutely brilliant top tip. So thank you very much for sharing with us today, and thank you very much for joining us.
Thank you.
Thank you.